Good morning to everyone. Good evening. This is a very important webinar for us because this is the first joint webinar between the European Society of Gastrointestinal Radiology and the European Society of Gastrointestinal Endoscopy. Everything started probably 3-4 years ago when the past president, Thierry Ponchon, decided to merge two guidelines of ESGE, one on CT colonography and one on colon capsule, in one clinical orientated issue, that is, what is the imaging alternative to colonoscopy? What if I have an incomplete colonoscopy? Should I do a CT colonography? Is this easy? Should I do same day or next day or whenever it is? This is why we did this joint guideline that is already on PubMed. Let me thank first our available long-term partner of ESGE Alpha Sigma to support this webinar and for all the support in this critical moment with COVID. We have a super faculty as all the time. We have our radiology guest, Daniele Regge, please, Daniele, who is associate professor at Turin University. Welcome, Daniele.
Hello, Cesare. Hello, everybody.
And we have from Italy, from Brescia, but he's associate professor of endoscopy at Catholic University, and he is the chair of the working committee small bowel for the KIC, and it's a pillar of ESGE. We have Cristiano Spada. Welcome, Cristiano. Okay, you can unmute Cristiano. Daniele, please let Cristiano speak sometime. Eh? Okay, so let's move to the next slide. And of course, we are expecting all your questions by Q&A, but you can intervene by chat. You can talk each other by chat. Go to the next question, and this is the disclosure of our consultant. Next slide. Okay, this is the first question for the audience. Most of us work in a fit positive setting, the same with Daniele and with Cristiano. So let us assume that I had an incomplete colonoscopy, and it was with conscious sedation because I don't have the anesthesiologist. So what would you recommend? The repetition of colonoscopy with deep sedation, CT colonography, colon capsule. It depends on the patient. We need to talk with the patient, or we repeat fit. Please don't take the last one. Okay, please respond. Okay, this is a very important question, and I am a bit angry with you, Daniele. Okay, Cristiano, first of all, do you agree?
Well, I would do the same. I will try to repeat colonoscopy with deep sedation.
Okay, but I must admit.
Also, Cesare, it depends the reason of incompleteness.
Yeah, but no, I feel that this shows some skepticism toward the CT colonography. And Daniele, this is my idea. Maybe I'm wrong. This may depend on the fact that it's not so easy to collaborate with the radiologists. If I go down and say, look, I had an incomplete colonoscopy, can you complete? They say, oh no, I need to do 5 CT of the head, etc. So Daniele, are you a bit disappointed by this? I would be disappointed if I were you.
But Cesare, what kind of radiologists do you have in your institution? I'm wondering, because I mean, we are very open-minded at our place. I mean, everything a gastroenterologist wants, we try to make him happy. So if he wants a same-day CT colonography right away because he doesn't want to have a new preparation, then why not? Or because he has occlusive cancer, then why not? Right away. I'll show you some slides about this.
Can I ask the audience to chat me if it is easy for them to have a CT colonography after incomplete colonoscopy the same day? Cristiano, can you do a comment on the no, you already did on CT colonography. Is it easy in Poliambulanza di Brescia, that is the largest, one of the largest gastro center in North Italy? Is it easy for you to have a CT colonography the same day? Tell the truth, please.
It's extremely difficult.
Daniele, please, we can start
Okay, you see,
we can start the webinar now.
I can see that many people are answering it's difficult, it's impossible. That might be the issue. I mean, we need probably also not only to educate gastroenterologists like today's webinar, but also radiologists around the world.
Okay, guys, the audience is record today, so please let's start with the presentation. Daniele, move on. No, Cristiano, move on, please.
Yeah, well, actually, we are dealing with incomplete colonoscopy. I'm looking at the audience. I know some of them. I'm sure that nobody in the audience has incomplete colonoscopy. Everybody has 100% of complete colonoscopy, but something happens. At least looking at the literature, something happens. What's your last time with incomplete colonoscopy, Cesare?
I did yesterday. It was a bit positive with a big hernia. In that case, I was forced to ask for CT colonography, but again, it was not easy. I felt very somewhat annoyed by it. Can I ask also the audience if they chat when they had the last incomplete colonoscopy? Because all of the people just say, oh, I have 100%. But then you make focus and you had incomplete colonoscopy. Please go on, please.
Yeah, well, if we look at the, also I'm reading Tassos Koulazidis, and also yesterday an incomplete. So something happens. And well, in general, if we look at the causes of incomplete colonoscopy, we have some factors that we can modify and some other factors where it's impossible to modify. Well, first, if we look at the patient factors, probably one of the most frequent causes of incomplete colonoscopy is the inadequate bowel preparation. So we are doing a lot to improve the compliance, the low volume regimens, improve the compliance to our patients. So probably, and the split regimens improve very much the cleansing level of our colonoscopy. So probably in the future, we will see a lower number of cases with incomplete colonoscopy because of bowel prep.
Chris, stop 1 second, because I feel we need to differentiate between an incomplete colonoscopy due to the anatomic factor or patient reaction and bad bowel prep. In the case of bad bowel prep, I would try to optimize bowel prep before sorting to CT colonography. Can the audience say if they did the same? On the other hand, if I have an incomplete colonoscopy for stricture or pelvic postoperative adhesion, in that case, I would straight away consider CT colonography or colon capsule. Do you agree, Cristiano and Daniele?
Well,
sorry, Chris. Well, there's an interesting observation that we are making. This is not published data yet, but we are observing that people that have long colons, they have more probability of having an unprepped, not adequately prepped colon. So maybe, you know, sometimes it's because of a preparation, but sometimes it's because of the constitution of the patient. So in these cases, maybe virtual colonoscopy could be an alternative if you have a very long colon.
Yeah, well, the other reason actually of incompleteness is factors that we cannot modify, like adhesions, strictures, or difficult colonoscopy. In this case, if we want to try again colonoscopy, we have some options like CO2 insufflation, the water immersion technique, or the device-assisted colonoscopy. Or we can also, that is always important, optimize our technique in colonoscopy with abdominal pressure position change. Then we never have to forget that one critical factor is the expertise. I mean, if we perform a high quality colonoscopy, probably we reduce the risk of having an incomplete colonoscopy. Do you agree with this, Cesare?
Yes, Cristiano, I feel that the main predictor of incomplete colonoscopy at the end is the endoscopist. Because when you get older, as we are, you know a lot of tricks to somewhat solve the issue. But I can understand that people who are out from training or in the first year's colonoscopy may have a higher rate of incomplete colonoscopy. In that case, please stop. Don't worry. You don't need to have 100% complete colonoscopy. What is important is the safety of the patient. Don't push only to get to the cecum. In that case, an expert or a CT colonography is a much better alternative. So I guess that when there are stricture, adhesion, etc., you need to do the best you can do. But if things don't get as they should, please stop. There is other opportunity to study the colon.
You know what happens when CT colonography is readily available? Sometimes the gastroenterologists won't try so hard. If they are not successful, then they will send it down to CT colonography. This is why, one of the reasons why the completeness in the completion rate in our institution is actually dropping in the last few years.
That's interesting.
And then the other reason is the suboptimal, let's say, sedation. And there is this paper that was absolutely clear in the results. If we use the anesthesia assistance, then the completion rates goes up to 98%, even in patients with previous incomplete colonoscopy.
I mean, Cristiano, I want to stop you 1 second on anesthesia, because I realized that also from our participant, a lot of people support this idea. But anyway, if you need to replan the procedure, you need to give a second bowel prep. You need to have the time in your schedule. You need to have the anesthesiology. So it's quite burdensome. If you could complete with the same day CT colonography, you would avoid a lot of issues. Can we ask the audience to chat us if they replan with the anesthesiologist the incomplete colonoscopy? Okay, please, Daniele.
Well, I'm not going to comment on this because, you know, I completely agree, but many of the participants have just said that they don't have CT colonography available.
Yeah, move forward, Daniele. Yeah, we can move forward with the webinar.
Okay, so now, you know, I've seen before that about 35% of you said that CT colonography was a good alternative. Okay, let's try to understand a little bit better. Let's go, just briefly want to introduce, for those of you who don't know too much about virtual colonoscopy or CT colonography, what is it? It's a specialized software that is useful to image the walls of the colon. And what you do is you put some seeds, the software puts some seeds inside the colon. These seeds expand. They recognize the surface between the air and the mucosa. All the excessive information is removed. And then there is a rendering. And so you have shades and light, and this is what you get as the colon is a three-dimensional view of the colon. This is called segmentation. And you can look at the colon from the outside or from a point of view that is inside the colon. So you can just travel through the colon in both directions. So if you, this is an example, for example, when you see something protruding inside the colon, this is probably a polyp or a cancer, like in this case. There are several studies that demonstrate that CT colonography has pretty much the same detection rate of colorectal cancer or polyps larger than 10 millimeters with respect to colonoscopy. This is a randomized study performed in England in symptomatic patients, in symptomatic subjects. And you can see here that there is a pretty much the same detection. And the limitation of CT colonography is more on the smaller polyps. You can see here in these two big trials where they're head-to-head trials with patients performing CT colonography and colonoscopy on the same day. And you can see here that as the size of the polyps gets smaller, then it's more difficult for CT colonography to see them. You can see that if you have a 5 millimeter or bigger polyp, you have a 65% chance. But if you go polyps larger than 10 millimeters, you see most of them. And all the per patient specificity is quite high. That said, we still need preparation. I don't want to give you the message that we don't need it. We need a relatively low volume preparation, usually with PEG. And we also use fecal tagging, which means we administer to the patient a solution of 70 milligrams of hyperosmolar iodine in a solution of water, and then about half a liter additional water. So one question is, well, what is the percentage of patients where we have inadequate? We don't call it incomplete. We call it inadequate, which is we are unable to report it, inadequate preparation or distension of the colon. Now, I'm referring to two important studies. The first study is the ESGAR trial, again, the one I've shown to you before. And in this case, you can see that inadequate preparation is in about 3% of patients versus, in this case, 11% of patients that had incomplete colonoscopy in the colonoscopy arm. In the screening trial, the results of the percentage of patients, of subjects that have inadequate preparation is much lower, especially if you're using a full preparation. So now, after having introduced CT colonography, I want to just push a little bit on the evidences in favor of CT colonography in incomplete colonoscopy. And as the guidelines, I want to divide this in two big groups. One is the stenosine, the cancer, stenosine cancer, sorry, to go back, stenosine cancer. And this is an opportunity for us to perform also staging. So we can perform both CT colonography. I don't know, I was trying to make the video work, but it's okay, here I see. Okay, in this case, we can perform both CT colonography and we can also stage the patient. Here, for example, you can see here, there's a sigmoid cancer. I'm going to try to stop at the right moment. If I can, okay, should work now. I'll just show you the cancer. Okay, the cancer is here. It's stenosine cancer, but this patient also had liver metastasis. Just show you the metastasis. Here they are, okay? And we know now that CT has a pretty good sensitivity in the detection of advanced tumors. And this could be used also for planning a neoadjuvant chemotherapy. And it also accurate in detecting distant metastasis. It has, however, a low accuracy in detecting nodal involvement. The other advantage of CT colonography for neoplastic region is the vessel mapping. We can also study the vessels, and that means the mesenteric vessels, the venous and arterial part, and we can provide reliable preoperative vascular anatomy. Sometimes that can change, especially when we're performing laparoscopy. It can change our approach to surgery. And also, one other advantage in this case is the opportunity we have to detect synchronous lesions. There are quite a lot of literature on this, and you can see here that this first point here is that CT contributed to change of the initial surgical plan of the surgeon in 20% of patients, and somebody also went through the prevalence performed a meta-analysis that identified the prevalence of colorectal cancer synchronous lesions for CTC versus non-CTC, generically non-CTC studies, and there's an advantage for CT colonography. How about non-neoplastic lesions? Well, in this case, I'm just going to pretty much refer what we have reported in the guidelines. In the guidelines, we say that in the setting of incomplete colonoscopy, due to factors such as pelvic postoperative adhesions or strictures, due to diverticular disease, inflammatory process, then colonoscopy is less likely to be successful, and CT colonography is a good alternative. I like to show this case. This is a case of a patient that had an enormous inguinal hernia, and actually in this case, colonoscopy was not even attempted, I must say, and we went directly to CT colonography. And you can see that actually this patient had hernia inside the hernial sac here, and you can see he also had a polyp. And I just want to add a few things about incomplete colonoscopy in diverticular disease, because the feeling is, we didn't go too much into detail in the guidelines, but the feeling is here that there is an advantage for CT colonography. CT colonography can clearly detect the longitudinal extension of the disease, how many segments are involved. In this case, you can see here in your upper right quadrant, 3D reconstruction, and you can see the polyps going all the way to the transverse colon from the sigmoid colon. But we can also see the wall, and so we can, for example, measure the thickness of the wall, and there are demonstrations that the thickness of the wall relates to the severity of diverticular disease. And actually, Dr. Flor from Milan with Perry Pickard developed a score which is called the diverticulate severity score, which is up here, measuring the severity of diverticular disease. So if we want to, and this is the guidelines, and what we say is that ESGAR, ESGE recommend CT preferably the same day, same or next day if colonoscopy is incomplete. The timing depends on the interdisciplinary decision, including endoscopic and radiological factors. So two more slides to just talk about the timing a bit. We've said that, we talked about it already. The vast majority, this is citing our own guidelines, the vast majority of patients can have a diagnostic study when same-day CT colonography is performed, with a minor increase in the time interval between optical colonoscopy and CT colonography. That means that we can perform the suggestion that we can have same-day CT colonography when available. Now, we know that it's not always available, okay? And so we need to work to make it, and I think that gastroenterologists should try to convince the radiologists to have it available right away, immediately. If it's incomplete colonoscopy, just have a phone call on the lower floor in our case, and we are immediately available to do it. Patients come down, they get the fecal tagging, they wait for 3 hours, and then they perform CT colonography. Of course, there are contraindications in case of acute cases like acute inflammation, and also we should be careful about patients that underwent intervention like hot smear or other more invasive endoscopic intervention, there is a justification to delay the CT colonography of a few weeks. Just about the quality of CT colonography, this recent article from 2020 is telling us that actually in most patients here, in this case, in this group of patients, 99% of studies that performed same-day CT colonography did not require a repeat CT colonography or a colonoscopy. I think this is about all for me. If I don't know how do you want to go on.
No, wait, Daniele, wait. So I want to admit that you are a winner when you say that CT colonography is indicated when there is a malignant stricture. I guess that all the endoscopists, I agree with you. Can you please chat if any of you disagree with the indication of CT colonography with the simultaneous staging after a malignant stricture? I guess, Cristiano, that you agree on that.
Yeah, absolutely.
Yeah. Okay. Now let's come, Daniele, to those cases without a malignant stricture. I am the first to recognize the importance of the SCIENTIFIC trial, but the feeling by an endoscopist, as I am, is that the quality of CT colonography is not so consistent in the community. I was interested in your last slide, Daniele, but honestly, this is not my experience. It may quite frequently come back the patient with a not well distended sigmoid. Of course, I already look at the sigmoid, but I don't like when the radiologist put another doubt on a patient that is already somewhat complex because I did an incomplete colonoscopy. So in colonoscopy, since 2006, Daniele, we strive a lot to improve the quality of our procedure. Do you feel that there is the same effort by radiology community in these years?
Well, I have to be honest. I mean, we, of course, organize training courses, hands-on, in the pre-COVID era, hands-on courses all the time, 2 or 3 times a year across Europe and across Italy. But I don't think we have, I have to be honest, I don't think we have the same rigorous approach that you have. That means also we don't have, for example, criteria, clear criteria to evaluate the experience and not the quality, but the experience of the radiologists that are reporting, which is something similar to the experience that the gastro. That, for example, you have something that is called, I think, completeness rate, right? And time of retrieval of the and these we don't have measures such as this one. We actually cannot even have them, right? Because we are doing a different type of examination. But probably in this, I'm critical with myself and my community that we can improve.
Daniele, I have a question that also is a question from the audience, and is about, Daniele, the role of barium enema in incomplete colonoscopy.
Okay, I think we should forget about barium enema at least in the setting of cancer. Okay, and cancer and polyps and cancer. Barium enema should be left only to to simplify, I don't think there is any residual indication of barium enema. And I will add that I think that it is even dangerous if you perform barium enema, because being that an inferior exam to CT colonography, if something goes wrong, and you make you don't make a diagnosis, you might have some legal problems. So I'm very hard on this.
Daniele, there is a question. If you have a cancer, okay, I mean, you diagnose a cancer at a CT colonography, do you always need the histological confirmation at colonoscopy? It may happen, Cristiano, that we do a biopsy on a cancer and it come back, it's insufficient for diagnosis because we took only the material from the ulcer. In that case, Daniele, you diagnose an invasive cancer. Is this enough for the surgeon to operate on?
Look, the typical thing that might happen is that you have a very long colon and the incomplete colonoscopy, or very long, or you have strictures or whatever, and there is an incomplete colonoscopy, and we find a cancer in the cecum, okay? Now, in that case, it's very difficult to try again, probably, to perform colonoscopy. And we go on, if the appearance of the cancer at virtual colonoscopy is typical, then we go directly to surgery. If we are uncertain, then we, of course, we try again for colonoscopy. But if it's impossible to reach this cancer, then we go directly to surgery.
Yeah, that's very important, Daniele. This is something that I learned in this year thanks to you. So I would invite all the endoscopy community to apply this paradigm. Cristiano, when we do colonoscopy, a lot of time we encounter diverticular disease, but at the end we don't stage, we consider it as a nuisance, non-neoplastic condition, only a problem to get in and blah, blah, blah. On the other hand, Daniele came out with very nice staging with classification, etc. Should we admit that CT colonography is a better tool for diagnosing and staging diverticular disease? Does our audience approve this? Can be this clinically useful, Cristiano, in your practice? And then we move to Capsule.
Well, I think that really CT colonography could add some information to stage the diverticular disease. On the other hand, I think that we miss other information that is mainly related to the inflammation. And I'm not sure, probably Daniele will help us, that CT colonography is very sensitive or sensitive enough to identify, let's say, like the colitis that is sometimes associated to the diverticular disease. So probably we should combine the two techniques if we want properly stage the diverticular disease, if it's needed.
Yeah, it may be needed for therapy. Here in Italy, we use rifaximin to prevent recurrence of diverticulitis. And I know that this is more and more also in France and other European countries. So let's move to Capsule. Okay, so what about the Capsule? The Capsule, we are using now the second generation of colon capsule is a non-invasive colonoscopy, patient-friendly. The new capsule, the capsule that is designed for colonoscopy, has 2 domes and is a sort of smart capsule because it can understand when the capsule is moving, and so it acquires 35 frames per second, and while when the capsule is sparking, it slows down to 4 images per second. So this adaptive frame rate is extremely helpful to reduce the risk of losing images. And in fact, in the meta-analysis that we did together, Cesare, we were able to confirm that the second generation of colon capsule in terms of accuracy is much higher, is much better than the first generation of colon capsule. So the other feature that is extremely important, in my opinion, is the angle. Now we have 172 degrees. That means that since we have 2 optical domes, we nearly cover
all the mucosal surface. We have two optical domes, so the same fold we can explore from one side and also from the other side. So this is the excellent images that we have now with the colon capsule endoscopy. At the moment we have an adequate cleansing level. We really have excellent endoscopic images. So what about the role of colon capsule in incomplete colonoscopy? Well, unfortunately, we don't have such huge, big evidence that Daniele has for CT colonography. We have a relative big number, but it's nothing comparing the numbers that we have with the CT colonography numbers. So what we can looking at these numbers is that using capsule endoscopy, we can complete the vast majority of the incomplete colonoscopy. But this makes sense, Cesare, because with capsule endoscopy, we explore the colon from the right side to the left side. So it's easy to explore the portion of the colon that have been missed by the conventional colonoscopy. And we are also, these trials look in terms of findings, we're able to detect additional findings, you see, between 24 to 45%. It depends if we consider only significant findings or all the findings that would have been missed because of the incomplete. So these lesions were located in the portion of the colon that were not visualized by the incomplete colonoscopy. So it's a good alternative to CT colonography. Well, we don't have data about an incomplete colonoscopy for neoplastic lesion. So we don't have trials that specifically went to analyze the role of colon capsule in incomplete colonoscopy because of neoplastic lesion. But if we look in general, the other reason of incompleteness, you see that the colon was visualized in almost all the cases with significant findings that have been detected between 24 up to 45% of the cases. Then we went to analyze also, to compare in the setting of incomplete colonoscopy, the colon capsule and CT colonography. This paper was published some years ago in GATT, and we were able to demonstrate that if we compare the two techniques, actually the colon capsule is more sensitive than CT colonography for both 6 millimeter and 10 millimeter polyps. The difference is statistically significant for 6 millimeter polyps and is borderline for 10 millimeter polyps. And if we go and to look what's the reason, which kind of lesions make the difference, actually were mainly flat lesion located in the right side of the colon. So it means that this is probably is not a definitive conclusion, because this is only one trial, but also other trials in different settings were published, and it seems that if we compare the two techniques, well, actually the colon capsule it's more sensitive than CT colonography. But again, this is a very preliminary. Tassos was writing now that probably it will come out a new study at the end of November comparing the two techniques. This is an example of an incomplete colonoscopy because of diverticular stricture. The capsule was able to detect, to visualize entirely the colon, to pass through the stricture and to complete the colonoscopy. So what's the recommendation of our guidelines? The two societies suggest that in centers with expertise and where capsule is available, well, this is a general comment that I think it's applicable for all the technologies. I mean, it's not only a problem of capsule endoscopy, it can be also for other tests, but anyway, the capsule should, we can consider the capsule in incomplete colonoscopy the same day or the next day. We have some evidence that we can perform capsule endoscopy immediately after an incomplete colonoscopy. We have two trials at the moment. One is from Ireland, and the other one is from Greece. And it seems that we can keep the same bowel prep that we used for colonoscopy. We need to include the booster. And at the moment, when this study were performed, the booster that was recommended or suggested was the sodium phosphate plus or without the gastrografin. And in this setting, it's possible with the same prep to complete an incomplete colonoscopy immediately after the incomplete colonoscopy.
Okay, wait, Cristiano. So you work in a tertiary center. I am a humble endoscopy in the community setting, okay? I can tell anything against CT colonography, but at the end, I have CT colonography in my hospital. You have CT colonography everywhere. On the other hand, if you ask me, do I have access to colon capsule for incomplete colonoscopy? The answer is no. Very few centers perform this procedure despite the wide availability of small bowel capsule. For instance, in my center, I do small bowel capsule, I don't do a colon capsule. So what are for you, and in the meanwhile, I would invite the audience to chat if they have access to colon capsule. What are the barriers for you to the implementation of colon capsule? Is it the cost? Is it the standardization of the technique? Is it the fact that the endoscopies are so relying on colonoscopy that they don't accept that there may be something different from colonoscopy? What are for you the main barriers that in the last 10 years prevented the implementation of colon capsule for incomplete colonoscopy?
I think, Cesare, that is a combination of the reasons that you were mentioning. For sure, cost is one barrier. The colonoscopy colon capsule is a quite expensive technology. The other reason is we don't have reimbursement. Actually, I was talking this morning with Jean-Christophe Soren. They did in France a huge project, and finally they get reimbursement for colon capsule endoscopy in case of incomplete colonoscopy. But let's say in Italy, we don't have it. And I don't know the other countries. Could be nice to know from the audience if they have reimbursement or not. I think that the other barrier that we should consider is the colon capsule is non-invasive, but Daniele was telling us about the prep that they use for CT colonography. That is like nothing. I mean, for colon capsule endoscopy, we still have a huge prep. We are working on this. We will reduce probably, and we were able already to reduce the regimen of prep, but I think that, and then the other problem I think is also a cultural problem. We like colonoscopy, and we are in love with colonoscopy, and we try to complete our colonoscopy, incomplete colonoscopy by ourselves, and we don't like to refer patients to other colleagues. So probably I think that the colon capsule endoscopy was not able to jump into our daily activity for several reasons. We should also admit that it was not easy to build evidence for colon capsule endoscopy. Daniele showed us huge numbers, huge papers, and well, I don't know the reason, but it was not so easy for the endoscopy world to have the same number that they have for colon capsule endoscopy.
Daniele.
Yeah, well, I have one comment is that, well, I don't want to get into this, but the performance of CT colonography in these studies is surprisingly low. So we need to have more studies on comparing the two.
Daniele, there are,
the second is a question, and the question is, what kind of incomplete, what was the reason for incomplete colonoscopy? Because I imagine not all indications of incomplete colonoscopy are good for capsule.
Yeah, absolutely. Well, in our trials, the reason of incomplete colonoscopy was mainly for non-neoplastic stricture or poor compliance of our patients. So we didn't have any single case of neoplastic incomplete colonoscopy.
Okay, and you never have problems with the capsule getting stuck somewhere? No. I'm sorry. No, not with the second generation anyhow. It was part of the old generation.
I would be afraid in case of neoplastic lesion.
And the second is more a question, but is a provocative question, which I always like to make. Cesare doesn't like it too much, but ideally, we should try to use a test for diagnosis, which is less invasive as possible, and then use colonoscopy for intervention. Now, I'm curious to know if endoscopists are happy to performing all such a high number of negative or uneventful examinations and have little space for intervention. I mean, this is a more philosophical, a more broad issue, but I think we need to discuss this sometime in the future, because I think we should go to this paradigmatic change. And in this case, the diagnostic test would be CT colonography and capsule, and the interventional test would be colonoscopy.
So, Daniele, let's sum up. So first, we agree with you, but we use a immunochemical fecal test for our screening program, and then we use colonoscopy. So we agree with you, but immunochemical fecal test came as a winner against less invasive tests like CT colonography, and I can say it would be the same for colon capsule. On the other hand, I agree with you that the endoscopy capacity is very limited. In Italy, we have 1 year of waiting list. So for people at very low risk of advanced neoplasia, CT colonography may be an option. And several primary care physicians here in Italy refer patients straightforward to CT colonography, bypassing us as endoscopy. So your paradigm is very well taken by us. But I have I have a nasty question for you, Daniele. I didn't want to do it, but the audience was it's very pressing.
Okay.
The main problem, CT colonography, is flat lesion. Please be honest on this, Daniele. The difference in between the Cristiano data and CT colonography data are given to flat lesion. So is CT colonography a test that misses systematically flat lesion and detect only big polyp and blah, blah, blah?
Well, I'm sorry, I don't have the opportunity to show the data, but yes, I mean, we are not as good as colonoscopy in detecting flat lesions, but we have a certain, I mean, yeah, on the average, let's say in a good quality CT colonography centers, at least with reference to the studies that have been performed, we should have around a 65 to 70% detection rate. Of course, depending on the size and depending on the definition of flat lesion, because there are flat lesions with different, then if we get into this, it will be a mess, because the real flat lesion, what is the definition for a flat lesion? That's a bit confusing always.
Okay, so
but
let's move
it's
on.
true that we miss a lot of small, let's say small flat lesions.
Thanks for your honesty, Daniele. You are exactly.
Yes.
Okay, second question for the audience. If there is a severe comorbidity, are we able to abandon colonoscopy? And what we do recommend? Please vote. Okay, this time is better for you, Daniele. When there are severe comorbidity and endoscopy may be tracking some nasty adverse event, then the radiology become our friend. Please, Daniele, give us some evidence.
Do you want to say something about this? I think you added these slides, Cesare.
Well, I think we can skip the definition of fragile patients, since we are on late, and we go directly, if you agree, Cesare, on, yeah.
Okay, so, okay. Now, well, yes, well, we radiologists believe that the fragile, the elderly patient is a good candidate for CT colonography for several reasons. Well, the first reason is that we don't need to be very invasive. We can use a minimal CT preparation with just a little bit of tagging and very low laxative. And because the aim here is not to detect the small 5mm polyp, but to detect the cancer. Now, this patient has a large cancer in the transverse colon. It's 87-year-old patient, I remember. You can see it very well, even if the quality of this examination is not very good. That's what you're aiming for, detecting cancer, okay? The advantage of CT colonography is that we have a lower complication rate, especially also for perforation. And also, I must say that usually we detect perforation immediately when we perform CT colonography. We can see if there's air outside the colon. And so it's an immediate finding. Most of these patients are asymptomatic. You can see this large series of over 50,000 patients. And most of these patients with perforation are asymptomatic. And many do about 50% of the 30% here, only 30% require surgery. And from the slides we skipped, I can tell you that and as you know, perforation risk is higher going into the older patient with respect to the younger patient. So this is one reason. Also, if you have a fragile patient, if you have anticoagulants, for example, then again, you can have bleeding, and people, at least in Italy, rather refer to CT colonography rather than colonoscopy. I think that that's about it. Yes.
So it seems that the audience is in line with your thought, but I want to be again a bit provocative with you. If what is important is just to detect a cancer rather than a polyp, isn't it a simple CT scan of the abdomen enough?
Cesare, unfortunately, if you don't distend the colon, you don't see it, you really get confused. So okay. Unless it's a large cancer, really large cancer, then of course you see it. But if you might even miss some big lesions. So you need at least to distend the colon. So,
this is a very important concept, Daniele.
yes, absolutely. CT scan is not enough.
Yeah, I was not aware as I should have about this, but this is very important for all the endoscopies. If you don't do colonoscopy, don't ask for a CT scan, ask for a CT colonography, because a small cancer could have been missed. Cristiano, is colon capsule safe?
Yeah, well, about the safety of capsule, I think we don't have a concern about the safety profile of the capsule. If we properly select our patient, then the capsule endoscopy has a very good safety profile, and the major complication, the complications are mainly associated with bowel prep, and the capsule retention is in colon capsule endoscopy is mainly related to small bowel capsule retention, and so I would not have concern about the safety profile of colon capsule endoscopy, even in fragile patients. There was a question from the audience. It was about the risk of capsule retention inside of a colonic diverticulum. Actually, I never had such kind of adverse event. We should pay attention to the Zenker diverticulum, esophageal diverticulum, because then there we can have the capsule retained. But in my experience, I never had any single case with the capsule retained in a colonic diverticulum.
Cristiano, let's be honest. One of the reasons we may decide not to proceed to colonoscopy in patients with severe heart failure or kidney failure is possible adverse event by bowel prep. So
Yeah.
we heard from Daniele that he can minimize in this patient bowel prep. So maybe we should accept that CT colonography, when there are severe comorbidity, could be a somewhat more reasonable choice. Do our audience agree? And first of all, thanks to be connected for so much time. We will be very long tonight, but you are fantastic. Daniele, so maybe you are a winner in this case, isn't it?
Well, I think he is a winner. He is a winner because, again, we are working on prep, but well, the prep that Daniele uses for CT colonography is really very easy, and I think that we should consider CT colonography in elderly and in fragile patients.
Well, unless you want to keep on going for colonoscopy on the 89-year-old patients, then I would agree with you. Yes, thank you for considering CT colonography.
Well, in fact, if we look at the guidelines, in this setting of fragile patient, the guidelines suggest that the capsule may be considered in patient with non-alarm symptoms, while there is no evidence at all to use in patient with alarm symptoms. So I would refer this patient directly to Daniele.
Okay, maybe we can jump to the screening. I feel there's a question for the audience here.
No, not now.
Okay, so anyway, can you chat if you feel that CT colonography may be an alternative to a primary screening colonoscopy in those countries where there is no fit program? Please, Daniele.
Okay, so since the last guidelines on CT colonography that were also done together with ESGE and ESGAR, there are three important clinical trials you must be aware of. And these are clinical trials that have been performed within screening programs, at least the two Italian trials. One trial was a randomized trial comparing CT colonography with optical colonoscopy. And the first one is the Amsterdam trial. Then we have the Proteus trial, and that's a randomized trial comparing CT colonography with flexible sigmoidoscopy. That was performed in my region and in Verona, because at the time we had flexible sigmoidoscopy as the primary test for screening of colorectal cancer. And then finally, the randomized trial between CT colonography and FOBT. And you can see here that basically you can see the adherence, the participation rate, which is superior for CT colonography with respect to colonoscopy. It's pretty much the same if we compare with flex sigmoidoscopy, and it's inferior with respect to FOBT. FOBT has a higher detection rate. And here on the last line, you can see the detection rate, and you can see here the different numbers. Pretty much CT colonography compares with flexible sigmoidoscopy. It's of course superior to one round of FOBT. Actually, now we have the study with after 3 rounds, and it is an equivalent detection rate. Okay, so these are the results. Other than this, there are some information about the cost in screening programs. And you can see that the cost of flexible endoscopy and CT colonography are pretty much the same. And the cost of FOBT is probably lower, depends of course on the number of rounds, okay? So this is the data we have. And with that, we still think that we don't have enough data to perform CT colonography in a screening setting, in a screening program. However, in the ESGAR guidelines, we do state that if there is no screening in a certain country or in a certain area, then we can consider CT colonography just as any other test like FOBT or colonoscopy or whatever, depending, of course, on patient-related factors, local services, and so on. In relation to also to screening, ESGAR, SCIENTIFIC do recommend CT colonography in cases of a positive FIT test with incomplete or unfeasible colonoscopy. There's evidence that if we re-invite patients rather undergo CT colonography rather than repeat colonoscopy, and this is a study from Florence that shows exactly that patients rather go for CT colonography rather than re-invitation. I think I've said everything. Oh yeah, I have to say that of course participation depends on the really on the preparation a lot and the feeling that patients have on the exam. There are now, we talked about preparation already, there are really now very low, very ultra low volume preparations like the cleansing preparation. Patients in this case only drink 500 milliliters of Macrogol, and they have very good quality preparations. You can see here, this is a case from La Sapienza, and you can see the excellent tagging here in the descending colon and the transverse colon. Okay, that's about all for me. If you want to ask questions.
I feel that Daniele, you show us the potential. Of course, FIT is dominating, and also colonoscopy is dominating. But I tend to agree with you that if some patients are unwilling to do a primary colonoscopy screening, or even if they are unwilling to do a FIT. And for instance, in Italy, 70% of population doesn't want to do a FIT. CT colonography could be an offer. But again, I feel that you would find much more reluctance, Daniele, from the radiology community to serve for a population-based screening than from us as endoscopists, because I'm not confident that in the radiology community there is so much time to dedicate to what would be a population-based screening, but maybe I'm wrong.
But Cesare, are you talking about the primary test or
no, as you suggest, for those who are uncompliant. So primary for uncompliant. So you invite me to FIT, I don't like it. You invite me for CT colonography, I come. Do you feel that the radiology community could screen all of these people?
I mean, it has to be organized like like an organized screening program. I mean, if we have the resources to do it, then we'll do it. I mean, that I don't think that should be a concern.
Okay, if then we can go to colon capsule, and then we can close the webinar because it's now more than 9 minutes beyond. Please, Cristiano.
Yeah. Well, Cesare, this time I will start directly from the guidelines, and so you know that there was a huge discussion about screening, and until the end there was like a very open discussion about this. So I will start on the recommendation. So the two societies do not suggest capsule endoscopy as first-line screening test for colorectal cancer, and the role of capsule endoscopy might be in case of FIT or FOBT positive patients with incomplete or unfeasible colonoscopy, again based on availability. So I want to show you a couple of videos where it's clear that we should not have concern about the ability of capsule to detect cancer. We are dealing with an endoscopic tool, so we perfectly visualize the mucosa, and the images of cancer is very easy, or polyp like in this case. So the question is why we are not able to use the capsule endoscopy like we recommend for CT colonography. I think that the main reason that was for which it was impossible for us to support the capsule endoscopy is not a problem of quality, is not a problem of accuracy, is not a problem of safety. The problem is lack of evidence. This is the trials that we considered to support the use of colon capsule in a screening setting. And look, these first two trials, Begonia Gonzalez, I saw that she's in the audience, and Brooke Cash were not considered in our guidelines because were not published. So if we compare the numbers from that was presenting Daniele and the numbers that we have here, really we cannot compare the two techniques. Capsule endoscopy is extremely accurate, well, extremely is accurate to detect polyp and cancers, but really we don't have evidence. I was mentioning Begonia Gonzalez. This paper was published a few weeks ago, and she went to compare the colon capsule and CT colonography in a FIT positive screening population. And again, it seems, looking at these numbers, that again, the colon capsule is more accurate in terms of detection rate and sensitivity when we compare a colon capsule to CT colonography. The same numbers were published a few years ago by Emanuele Rondonotti, again in a FIT positive screening patients. He was also able to detect, to demonstrate that the capsule was more accurate than CT colonography. And also this American trial from Brooke Cash, again, they were able to demonstrate that is capsule endoscopy more sensitive, the diagnostic yield is higher for both 6 millimeter and 10 millimeter polyp. So I think that, again, we should admit that the problem is not the accuracy. The problem is not the safety profile. The problem is that CT colonography has a huge evidence to support the role of CT colonography. Also in a screening setting, colon capsule, unfortunately, is building this evidence during these years. Then we have the problem of refusal. You were mentioning before the patients who refuse colonoscopy within a screening program. Well, I don't know. I would like to ask Daniele what's his opinion about the ability of CT colonography to recall patients who refuse colonoscopy. I was reading this paper a couple of years ago by Mathieu Piochet, and he went to see if the colon capsule and CT colonography were able to include, again, to test in patients, FOBT positive patients unwilling to undergo colonoscopy. And the result was, well, let's say dramatic. I mean, only 5% of patients who were recalled, they accepted the colon capsule, and 7.4% underwent CT colonography. So I think that the message is that finally, I don't know, at least for colon capsule endoscopy, in my experience, patients who refuse colonoscopy are very, very difficult to be involved in other tests. I don't know if it's the same experience of Daniele, and I would like also, Cesare, to know your idea about this.
Well, I mean, I showed this study in a screening setting in Florence, and there was some more attractiveness for patients that were re-invited to perform a screening test towards CT colonography. But again, I mean, we need to examine this a bit more and have larger studies, which I don't think we have anymore. We have yet. So I don't have a definite answer on this.
I guess that we should compare first CTC and colon capsule for uptake. And according to our audience, also according to cost and availability, and then can move to a direct comparison in accuracy. Do you have other slide, Cristiano?
Well, about the patient refusal, I have another slide that is about this trial that you know very well. This is a trial that was performed by the group of Enrique Quintero and was published in 2015. So it was a very elegant trial. They went to analyze relatives of patients with colorectal cancer, and they randomized patients in a group of colon capsule and in the other group of colonoscopy. But they allowed them to jump from one group to the other. So the hypothesis was that the majority of patients who were allocated in the colonoscopy group could jump in the colon capsule group. But this was not the case. Most of the patient, most of the people that were allocated in colon capsule group jumped into the colonoscopy group. So the main reason, I think, and what we should learn from this is actually that people who are aware about the risk of having a colon cancer, they want colonoscopy, they accept colonoscopy, and they refuse other alternatives. But then in this trial, there is a subgroup that was about 15% of patients that jumped from the colonoscopy group to the colon capsule group. I think that this should be the target of colon capsule. So really, it's another option. We should expand the option for screening, and we should include CT colonography and colon capsule just to increase the number of patients who get screening.
Yeah, the trial by Enrica showed that if you don't do research, you would never ever anticipate.
As I said
the
before,
complementary role among the technique is critical to improve the uptake. Please, Daniele.
Yeah, I was saying, maybe you didn't hear me, that I fully agree with Cristiano, and you said that adhesion to screening programs is suboptimal, below 50% usually, even with FIT. So we should offer alternatives to this. And alternative can be CT colonography, capsule, colonoscopy. I don't know, maybe.
Daniele, last question, and then Dave, please, we move to close this webinar. So a lot of questions for you. Does CT colonography prevent cancer or cause cancer with radiation exposure?
Yeah, this is a good point. Do you hear me?
Yeah.
Sorry, because I had some kind of interruption. So this is a good point. What I can say is that we cannot absolutely exclude that that CT colonography may not cause cancer, but the doses of radiation that we are using now, because of the new CT scanners and with the new reconstruction algorithms, are much lower than the ones that we were using even 5 or 10 years ago. We are going down below 1 millisievert, and there's evidence that at that very low dose, it's going to be very improbable that we can develop a secondary cancer from radiation.
Thanks, Daniele. So I feel that it's time to close this webinar where there was an outstanding audience. Cristiano, I feel that all of the endoscopy community must pay tribute to Daniele and to the ESGAR for what they did in our guideline. You, Cristiano, and Daniele did the most of it, but I feel that the collaborative, sometimes a bit less collaborative climate was critical, and we'll definitely continue to work together for doing this important guideline document. So Daniele, I don't know how to thank you. You were outstanding throughout all the process, and
well,
really
thank you, Cesare, for the invitation, of course, also to this webinar. I see it's really well attended. I was very impressed.
Yeah.
Thank
Okay.
you. Thank you very much.
And Cristiano, of course.
Thank you, Daniele.
And can we say also to the ESGE organization behind the screens? Huh?
Yeah, to David and Gabriella, thank you very much.
Yeah, so Cristiano, next week, you cannot miss the symposium on artificial intelligence. I know you are working on it. A lot of people are working on it. Daniele, this is the new gadget of colonoscopy. But very importantly, Cristiano, did you submit your abstract for ESGE days?
We are preparing the abstract to submit. What about you?
I'm preparing the abstract to submit, and so we must do this because this is the most important, critical, influential event in the endoscopy community here in Europe, or maybe also beyond Europe. So please put it in your agenda, send your abstract. There will be a lot of our presentation. All the top abstract will be priced, so we are just looking forward to this. So thanks, and bye-bye.
Bye-bye, everybody. Thank you.
Thank you.